Well, good morning for those who it's still morning, and some of you are in places where it's afternoon or maybe even night, but welcome to the management of Raynauds and digital ulcers. As Tina has mentioned, I started in 1971 in my training. Dan First and I were trained by the same professor, Harold Paulus. He had spent his entire career conducting, designing, analyzing trials in rheumatoid arthritis, and there were a lot of randomized controlled trials. There had never been a randomized controlled trial in scleroderma, and Dan and I, with his coaching, put one together. Was a drug that you've never heard of, N-acetylcysteine, but it was the first published year-long trial, randomized controlled trial in scleroderma. Since then, the industry has blossomed. In any event, I'm going to talk about the management of Raynauds and digital ulcers. Slide. So I'm going to do this on a case-by-case basis. That's what the medical educators think is the best way to do it. Years ago, Elaine First, I've known Elaine as long as I've known Dan, and that's 1973. She would go and listen to me talk about this and so to patients and professionals. And she came up to me one time and said, you know, what I'd like you to do is give a lecture to patients, the same lecture you give to the doctors. I gave this lecture to the doctors yesterday. So you're pretty much going to get what they got. I will try and soften some of the sharp stuff so that there's understanding. I'll try to avoid jargon when possible. Anyway, Jennifer, and you may recognize her if you're a movie buff. She's a 22-year-old white female who presents for evaluation of her complaint of my fingers turn white when I reach into the refrigerator or put my hands in cold water. She reports that the white turns to blue as my hands warm up. If I can't get my hands in warm water, the whole episode is, if I can get my hands in warm water, the whole episode is over in a few minutes. These white and blue color changes have been happening for about 2 years. She denies the occurrence of any sores on her fingers. In her health review, she denied any symptoms that would suggest that she has an autoimmune or rheumatic disorder. She denies smoking. Slide. So we did some lab work. The ANA was negative. In scleroderma, it's positive about 95% of the time. So this was negative, as was her rheumatologic panel. So we screened her for scleroderma. Back up, yeah. I screened her for lupus, screened her for Sjogren's, screened her for rheumatoid arthritis. That was all negative. She now needs her nail fold capillaries examined. Next slide. So the office procedure of looking at capillaries is fairly simple and cheap. What you see there for magnifiers are microscope eyepieces, 10 power. That's good enough. And then there are a couple of ways to add lubricant to the skin near the cuticle so you can actually visualize the capillaries better. Next slide. So there are a lot of different ways to magnify, and everybody gets used to their particular way. I prefer the 10 power microscope eyepiece, and I now buy them $12.50 and give them to new fellows. Jeweler's loops. I have a jeweler patient who tells me you got to spend 25 bucks more to get a good loop. Dermatoscope came out really expensive, marketed to dermatology for $250. In the intervening years, the generics have come along. All it is a light and a 10 power lens. And if you're really into it as a doctor and doing research, you'll spend $10, $15, $20,000 to get a really good apparatus. Next slide. So this is the way I do it. I take the microscope eyepiece, turn it upside down, and then slowly move it up and down as I look at the area of skin just next to the cuticle, and use a light, and it's often just a pen light. Next slide. So what I would like to see in otherwise healthy individuals is what looks like a little picket fence. And the little pink or tan lines that come out of the reddish area and towards the cuticle are all little tiny capillaries. And the capillaries bring blood down, they make a U-turn, and they take blood away. In the otherwise healthy individual, you don't see the loop. But, oh, next slide. Ooh. I'll come back to this in a minute. So anyway, I should point out that the largest group of people with Raynauds are menstruating females whose Raynauds began in the late teens and early 20s. They are otherwise healthy and will never have a complication from Raynauds. They will have normal capillary exam. Next slide. So Raynauds phenomenon is a temporary color change, usually lasting no more than about 15 to 20 minutes. You can shorten it by sticking your hands in warm water. That's what Raynauds initially described, the come and go kind of color changes. And that's still the way we talk about it in rheumatology circles. It's a temporary phenomenon and skin comes back to normal. Next slide. So in the top part here, you don't see any red in there. That's because the blood vessels have clamped down in such a way that the blood has been stripped. So that leaves a white finger. If on the other hand, blood gets trapped in the finger, it gives up oxygen and the hemoglobin there goes from red to purple, and that's why your finger changes to purple. And then finally at the bottom, in scleroderma, it's unusual to have people get a real red ending to the phenomenon, and I'll tell you why in a minute. In primary Raynauds, healthy women, they do often get pink hands at the end of the Raynauds cycle. Next slide. So this is a picture of a normal artery in primary Raynauds phenomenon. You have arteries that supply blood down to the base of the fingers and out into the fingers, and then they turn into capillaries. But this is normal. There's a wide open space. There's a red area around the whole thing, which is muscle. It can contract or it can relax. And then you see little things on the inside, which are part of the lining cells. Next slide. In scleroderma, things are different. And particularly if someone is developing an ulcer, you can bet that they have narrowing of the internal opening. And that dark blue stuff is hypertrophy of the inner lining of the artery.
Vessels look for a normal person and somebody with Raynauds.
I'm sorry?
Can everybody please keep muted during the talk, please?
Yeah, I can.
Hold on, Dr. Clements. I have no idea who's speaking and I'm trying to see. Can everybody please mute?
So anyway, the lining thickens. It's unclear exactly what that stuff is in there, but some people think it's a collection of a type of fibroblast called a myofibroblast. Myo means muscle, fibroblast means collagen. So it's a cell type that can constrict, narrow the opening. If you get a collection of them around the internal lining, then you quietly shut down the passage of blood. This is what underlies a lot of the problems in scleroderma. Blood vessels throughout the body have this going on. They lose the caliber, so there's less blood that can get through. Next slide. Next. Oh, okay. So here's a contrast between primary and secondary Raynauds. Primary are the young women or older women as they age that have the phenomenon, but they don't have anything else wrong with them. The secondary is usually scleroderma in this case, but it can be lupus, it can be Sjogren's, it can be a number of other disorders. But we're back up. We're just going to contrast what happens in scleroderma. So in the primary, arteries look normal, and in the secondary, they have structural defects, narrowing structural defects. In primary, skin returns to normal and no skin damage. In the secondary, skin may have ischemic skin changes, and I'll show you some as we go along. Primary never has a skin ulcer. 50% of people with scleroderma will have at least one ulcer in their lifetime. Primary, normal nail fold capillaries. Secondary, abnormal nail fold capillaries. In primary, no associated connective tissue disease. And secondary, often there is an associated connective tissue disease. Next slide. So in the upper right, we looked at what normal is. It's a palisade, a picket fence of pink or tan lines that come down to the cuticle. You'll notice in the right upper one, you start to see, slide forward. Yeah, you start to see dilated capillaries, and you start to actually see the loop. If you see the loop, usually it's abnormal. Next slide. And if you go down to the lower left, you have a bunch of curly-cued looking capillaries, and you're missing a lot of capillaries. So the capillaries have thinned out, and the ones that are left are abnormal. Next slide. Now, it turns out the blood that flows through these capillaries sometimes leaks out because the capillaries are not normal and they leak. And it leaks red blood cells and hemoglobin. And hemoglobin is metabolized in the tissues down to the iron molecule at the middle. The iron can react with other things in the environment, and particularly oxygen. And that's iron oxide or rust. Literature doesn't call them rust, but they are rust. They call them cuticle hemorrhages. Next slide. Oh, I should note, those changes are seen in 2 diseases only. Scleroderma is one, and dermatomyositis is the other. Okay, so now we're going to talk about management of Raynauds, and we're going to do it by several levels. Mild is color changes. Moderate is when you start having digital ulcerations, and severe is when you have black fingers or shrinking fingertips because of necrosis. That's starvation, kind of. Next slide. So here, non-pharmacologic stuff is very important. It's often simple and people won't do it, but they keep hammering at it, and eventually they start getting the message that they ought to layer up, and they keep the extremities warm with hat, mittens, boots in cold climate. Avoid stress if you can in today's lifestyles. That's emotional or cold, and stop smoking. We showed with thermograms that within 1 or 2 puffs, you change the skin temperature in your fingers by several degrees. Next slide. So these are things I found on the internet. They're easily found. You can probably go down to some of the stores, which you can get them online or through Amazon. A neck gaiter, I used to use them with skiing. They protect your neck and prevent cold from going down your blouse or your whatever on top. So it seals your body off from cold weather. There's a cowl neck scarf. There's a cuddly duds fleece weather, cold weather scarf, multicolored scarf, cable ring scarf. Doesn't matter what kind it is. Oh, next slide. Then the hand warmers, most of you are probably already familiar with this. The disposable ones work for some people. They put it in the glove next to the skin. It never gets hot enough that it's really going to do damage to the skin. It's going to feel warm, but that's the purpose. You can put it in your toes. Then there are rechargeable hand warmers. The Brits have been big on electrically charged hands and gloves and stuff. And on the lower right is AA battery powered gloves. The batteries get used real fast. So if I were to get something, I would probably get a rechargeable hand warmer. Next slide. Then there's lightweight long johns underwear. When I go skiing, I use silk. It's very lightweight. It really protects your skin. It can be the lower layer, and then you put shirts on top of that, maybe sweaters on top of that, and maybe coats over that. So there's Walmart Climate Right Cuddle Lugs, Thermosilk, Rocky Women's Thermal Two-Piece, Cold Proof. Some of these are about 15 to 20 bucks for a pair. Next slide. Jackets and hoods. Hoods are good. Again, they stop cold weather from going down through your neck and into your upper chest. So there's the Burlington hooded jacket, there's fleece with hood, hooded mesh lined active jacket, Hanes full-size sweatshirt with hoodie. So these are only some that I was able to find. Next slide. And then we get the hats. You lose a lot of heat through your scalp. I haven't been able to figure out exactly how much you lose because the literature is all over the place, but you do lose a fair amount. And it can be anything that closes your scalp off from the outside. So it can be a beanie, it can be a hoodie hat, a winter beret, or it can be those silly hats that the women are wearing down at the bottom. Pardon the pejorative of silly hats. Next slide. Then we get the gloves, the long fingerless gloves. Some people like to have their fingertips out where they can use them on a typewriter or some other project. So they don't necessarily need one that covers the whole hand. There are some that have a little attachment. It can be fingerless, and then you throw this little attachment over it and becomes a mitten. There's fingerless gloves, hand ease therapeutic gloves, fleece warm gloves, mittens. Next slide. If that doesn't do it, there are medicines that can. There's some people that are medicine averse, and that's fine. I have no problem with that. If they do want to take it, there's a group of calcium channel blockers that are known as dihydropyridine. The generic names are nifedipine, amlodipine, felodipine, and isradipine. And we tend to use them, start out at a low dose and slowly increase till we get what we want. They've never been shown to heal ulcers, however. They may cut down on color changes and numbness of the fingers, and some people have pain in their Raynauds, may cut down on that. It does not heal ulcers. Fluoxetine is an antidepressant. There's one randomized controlled trial in primary Raynauds that showed that it did help Raynauds. Whether it will help in scleroderma, I don't know. Losartan is an antihypertensive. There's also a randomized controlled trial that shows that it may work in mild forms of Raynauds. Next slide. Okay, so this is actually a person that I took care of years ago. She unfortunately has since died, but I've been at this for 50 years. So Alice is a 25-year-old female whose scleroderma began 5 years ago with the onset of Raynauds and swollen hands and fingers. Her skin thickening was limited to her fingers, hands, and face. She has been doing fairly well until about 1 month ago when she developed a painful, slightly swollen third fingertip of the left hand. In the past week, the pain in the right third fingertip has gotten worse, and now her right second fingertip also hurts. Next slide. So here we have her hand, and you can see two black areas on the second and third fingertip. That's the equivalent of an ulcer. That means that she's got structural damage. No surprise, because in scleroderma, when you get an ulcer, you usually have structural damage that narrows the caliber of the vessels. So her blood pressure is normal. A black scab overlies a painful third fingertip, and there's tenderness and pressure on the second nail. Fingers appear puffy. The remainder of the exam is unremarkable. CBC in chemistry is normal. ANA was positive at 1 to 160. In scleroderma, the ANA is positive 95% of the time. Next slide. Then there are scleroderma-specific antibodies. Some of you may have had a couple of these. Some of you may actually have had all 7 of them. I used to be somebody who thought I was a good enough clinician. I didn't need these antibodies. I've had a conversion. Virginia Steen is the one who popularized these. And I think it really does help us give some idea of where a person's scleroderma is headed. So anti-centromere, anti-SCL70, anti-PMSCL, anti-RNA polymerase 3, and anti-U1RNP. Those are the easy ones to get on everybody's computer. There are a couple that are harder to get. We can get them through the UCLA lab, but it goes to LabCorp. And LabCorp bought RDL a few years ago. RDL was around since I was a fellow, and a couple of my classmates set up this lab, and they worked really hard to get very specific, very good results with their lab data. So you can get anti-THTO and you can get anti-fibrillary, but it requires going to LabCorp slip and looking for RDL. And then you can get a scleroderma panel. And that sometimes can be useful. Next slide. The patient's lab work showed that ANA strongly positive at 1 to 12 or 2560, anti-centromere strongly positive, anti-SCL70 negative, anti-RNA polymerase negative. Next slide. Next slide. So these are examples of different ulcers. That's on an elbow. Next slide. And again, something that Neil Jones, a hand surgeon that I've worked with at UCLA for 40 years, has spent a lifetime working in scleroderma and Raynauds. So anything he has to tell me, I believe. And he impressed upon me that yes, people with scleroderma do get Raynauds. They get temporary color changes that go away with warm water. If you have a blue finger that stays blue and hurts like hell, that's ischemic disease. Because Raynauds comes and goes. Next slide. And next slide. So these are all examples of ischemic disease. There's not enough blood getting down there. It's not that Raynauds has gone into spasm. It's that there are structural changes in the arteries and capillaries in your fingers and elsewhere in your body. Next slide. So now I'm going to contrast the anatomy of a normal artery versus a scleroderma artery, and these are real arteries that I'm showing you. On the left-hand side, again, you've got the red area, which is muscle, and the little black dots on the inside are the intima, and then there's a big open space where blood can go through. On the other hand, on the right-hand side, there's that blue stuff, in the middle of the artery, plugging it up. Next slide. Oh, yeah. Reduced blood flow impoverishes tissues and favors the development of a digital ulcer. So on the left-hand side, there's a boo-boo on that index finger. You look over there and it's got the thickening of the internal lining, whereas the normal below has a wide open lining. And as a result, there's progressive obliteration of the vessel lumen and loss of blood flow, and the finger tissues start to die. When that happens, they hurt like hell. If I see somebody who's had an ulcer for a couple of months and I say, does that hurt you anymore? No, it quit hurting a couple of weeks ago. That's a good sign that the body has decided what's going to die and what's going to stay. And you can bet from here on in, there's not going to be a whole lot of pain and the healing is going to happen. When it's still active, it hurts like hell. Next slide. Okay, so if fingertip ulcers appear or calcium channel blockers fail, and they will fail if you've got an ulcer or a black area on the finger, because calcium channel blockers are just not strong enough. So we then move up the ladder to what are called PDE5s, phosphodiesterase inhibitors. They were originally brought out for erectile dysfunction, but it turns out that they help dilate vessels on the right side of the heart in pulmonary hypertension, and they improve the circulation in the fingers. The two that we have that have been well studied are sildenafil and tadalafil. Now, there is an or here, and you do not want to use nitroglycerin ointment while you're taking sildenafil or tadalafil. There are people who have done that and they've fainted, passed out, or died because their blood pressure dropped precipitously. So you can use nitroglycerin ointment by itself, or you can use tadalafil and sildenafil by itself, but not the two together. So the pictures just show different bottles of how this stuff comes. Next slide. All right, so 40 years ago, this study was reported in Lancet, a United Kingdom medical journal with a wide circulation, and it gets wide use in articles. So it's topical 2% nitroglycerin paste, which is how it comes. It's called Nitrobid 2% or some other thing like that. It can be applied to the proximal 2/3 of the fingers that have a fingertip ulcer. I'll show you a picture in a minute. Apply 3 to 4 times a day. After 20 to 30 minutes, you can wash off the ointment with warm water. Next slide. So here you got an index finger with a really painful boo-boo at the end of that. Next slide. So you put the goo not on the wound. It'll hurt like hell and won't do the job. What you do is you put it on the proximal 2/3 all the way around the finger. Side effects can come about the more you put on at a given time. So if you have one finger, you're unlikely to get much in the way of side effects. If you put 2 or 3 fingers, you may start getting them. It's because the blood vessels have opened up and all the blood's gone to your feet and out of your brain. So when you start it, if you got one, usually you're not going to get into trouble. If you got a couple, I would start with one. If that goes okay, then start applying it to the second one and the third one. And when you start getting lightheaded when you stand up, it's too much. You got to back off a little. Next slide. All right, so that's the nitroglycerin routine. We still use it. There has never been another trial like that one done in that way. What they did in that trial of nitroglycerin, half the group got nitroglycerin and the other half got a placebo. That study has never been repeated. People want to put nitroglycerin on one finger and one hand and watch what happens in the other. Well, you absorb the stuff. You absorb it through your skin, gets into the lining of the blood vessels, broken down to nitric oxide, it then leaks into the blood, which goes down to the finger, and that's to try and open the circulation downstream. No trial has done it properly. So I believe it, and I still use it. Okay, now we get down to the oral PDE5 inhibitors. Sildenafil, Revatio is another name when it's used for pulmonary hypertension. Viagra, if it were used for erectile dysfunction. Tadalafil is another one. Both of these have gone through sophisticated analyses, and they heal and prevent ulcers. These things are slow to heal anyway, but they make them heal a little faster. So they're part of our armamentarium. Now, if we have somebody who presents with an ulcer and try and use this as the first drug, the insurance company will routinely decline it. What they want you to do is go on a calcium channel blocker first. We know that doesn't work, but to appease them and make it easier for you to get the sildenafil or tadalafil, we do it for a month. We then reapply and say, calcium channel blocker didn't work, and we want to start sildenafil. The 20 milligram is the one that's often used in pulmonary hypertension, and those that review the doses and the strengths will let that pass. If you go for 25, 50, and 100, that's the dose that was used in erectile dysfunction, and they'll never approve it because it's recreational. Doesn't matter that we're not using it for recreational and we're using it in females. It just doesn't. It's crazy. In any event, these drugs are effective. Next slide. Okay, this is a study from Germany, now 17 years ago. It was the first that looked at sildenafil versus placebo in a randomized controlled trial. It was double-blinded, meaning the patient didn't know what they were getting, and the doctor that was applying it didn't know what they were getting. Fixed dose crossover. Patients were randomly assigned to take placebo or 50 milligrams of sildenafil twice daily for 4 weeks. Then there was a washout of 1 week, and then people got the other drug for an additional 4 weeks. So clinical and Doppler flow studies. Doppler is part of ultrasound, and when you're looking at Doppler, you're looking at blood flow. And they got studies of the capillary flow at baseline, at 4 weeks, and 9 weeks. Next slide. So the shaded box is the good effect. The number of Raynauds attacks during 4 weeks dropped. They kept a diary, daily diary. Cumulative duration of Raynauds attacks during 4 weeks went way down. And the Raynauds condition score was a visual analog of 0 to 10. And you kind of mark on that line where you think you are. And that got better. So everything was favorable. Next slide. They then did the Doppler flow. And you'll notice in A, the first section, they were on placebo, and the flow didn't change. They then got put on sildenafil, and the flow improved. In B, it was just the reverse. They started with sildenafil, it got better. They were put back on placebo, and it dropped. And at the bottom, you see mean capillary flow velocity. That's how fast blood gets through there. Is shown for all 16 patients with secondary Raynauds phenomenon, meaning scleroderma. So that was a convincing study. Next slide. There weren't enough people with digital ulcers to make a statistical statement that they healed them, but they noticed that it looked like they were healing ulcers, and the placebo did not heal ulcers. Next slide. Okay, so this is from something called a meta-analysis. So they took the data from Fries, Herrick, and Shenoy, those are the upper left-hand corner. Those are the study authors. They took all those and pooled them and then looked at them with something called a forest plot. And that's the graph on the right. And there is a diamond in the middle of the slide. Next slide. The diamond does not cross the line of 1. That makes it a statistically significant result. That is for improving Raynauds. At the bottom, you see the diamond, and they're looking for healing. And there was more healing in the sildenafil group than there was in the placebo. So there we have convincing evidence that sildenafil and tadalafil work. Next slide. So the course got more complicated. 2 months later, the patient returns with several very painful, infected-looking, deep cutaneous ulcers on the fingers. Now, this is a patient from Neil Jones from 40 years ago, but it still applies. And you'll notice on the right, there is an angiogram, and the yellow arrow is pointing to something that is missing. And that is the ulnar artery is plugged up. You look down at the bottom of that wrist, and there's a radial artery. So Neil mentioned that by the time he sees people to do anything, half of the people have obstructed their ulnar artery. So they get all kinds of obstructed arteries. If you get into the palm, the arteries there are narrowed. They get into the arteries in the fingers, they're narrowed. And you got the big supply chain, half of it knocked out. Radial and ulnar do not fit hand in glove. They kind of pull the blood into the same area, but they're not an anastomosis. They're not connected one to the other. So in this patient with a lost ulnar, he or she can limp along with what can get through the radial, maybe. And this patient didn't. I mean, it got a lot of ulcers. Next slide. So now we're treating severe digital ulcers and ischemia. So a complicated ulcer would be an infected one, so you need to treat infection. And a lot of the open areas of ulcers do get infected. And I have a low threshold for using antibiotics to try and kill off an infection that may be impairing repair. And you want to get pain relief. Before the feds got really nasty about Norco and Vicodin and made it hard to get, I used to use a fair amount. I don't anymore. And that's in part because I've learned a lesson, and that is, although it would be nice to have people take these medicines and stop them when they don't need them anymore, they often continue taking them, and essentially they become addicted. They can still function, but they can't get along very well without the medicines. So I use pain relief in a different way. And amputation sparingly. Next slide. And to promote healing. There you see sildenafil, tadalafil, and or nitroglycerin. But you also see something called ipoprostenol. Years ago, we did a trial of iloprost. In the parlance of chemistry, they're prostaglandin I, or PGI. They are in the body. The real prostaglandin I is made by the lining cells of the arteries, and it leaks into the circulation and goes downstream when they want to send the message to open up. Endothelin is just the opposite. It's also made in the lining of the arteries, and it leaks out into the circulation and says constrict or narrow. So there's a balance back and forth normally. What happens in scleroderma is there's too much constriction, and ipoprostenol helps to dilate the blood vessels. Next slide. So iloprost was a drug that we studied 25 years ago and found to be effective. Unfortunately, shortly after we published it in a prestigious journal, the company went broke and iloprost disappeared from the United States. It's still widely used in Europe. We don't have it, but we have epoprostenol or Flolan, and that is a drug that has been found to be effective in pulmonary artery hypertension. Nursing staff gets a little queasy if you try and use this drug outside of an ICU. So if we get a patient who really needs this kind of medicine, we have to get hold of the pulmonary hypertension people and say, please admit this patient for a couple of days, give them epoprostenol, and then you can let them go, and they're going to be easier to manage with standard drugs. Treprostinil is around, but there are no good studies that have looked at it in Raynauds and digital ulcers. Next slide. So this is a study that we did and published in 1994, which showed that iloprost was effective. What we did was we randomized them to intravenous iloprost or intravenous placebo. We infused them for 6 hours each day for 5 consecutive days. And then they were released, were followed every 3 weeks for 9 weeks after the infusions. Some of the people were brought into the clinical research center. Some were managed purely as an outpatient. Either way, it looked like it worked. Next slide. And the red boxes tell the story. So the weekly attacks decreased. There was an improvement in Raynaud's severity score. That's a visual analog that the patient fills out. Improved MD global, that's what the doctor fills out. And noticeably, there were people that had ulcers, and 20% of them had a reduction in ulcers of 50%. This was with 5 days of iloprost. Iloprost. Next slide. So what we came away with was iloprost was significantly better than placebo on multiple measures: mean number of Raynaud's attacks, Raynaud's severity score that the patient fills out, MD global that the doc fills out, number of patients who had greater than 50% healing of their ulcers, and reduced the number of new ulcers. Next slide. Unfortunately, the company went broke. Nobody has come back and been able to show, or even tried to show, that iloprost could get approved in the United States. So we are left with epoprostenol. Next slide. Again, with pulmonary hypertension service, we can get people admitted into an ICU, and they'll get IV epoprostenol for several days. It's 24 hours a day. We haven't studied it formally, but those of us that have used it feel that it does give weeks, if not months, of improvement in the ulcers. Next slide. Again, this experience suggests that several days of infusions can have a salutary effect for weeks. So it kind of resets some kind of thermostat and reduces the vasoconstriction and improves the circulation to the fingertips. Next slide. This is a controversial subject. Bosentan is an endothelin receptor antagonist. Remember, I said endothelin is excreted by the lining of the blood vessels, and its message is to constrict. So what we did was we tried to use bosentan to knock down endothelin levels. What was found was it did not heal present ulcers, but if you had 4 or more ulcers in your hands, you had a chance of preventing new ulcers by 50%. Macitentan is the newest on the block, and it didn't work. Bosentan did 2 trials exactly the same and came to exactly the same answer. Europe has approved the drug for prevention of ulcers. The FDA has not approved. It would flood the market with a drug that is probably $50,000 to $75,000 a year and may have limited usefulness. There are people who are still on it who swear by it. I don't put much credit myself in their use. Next slide. So this is the way the studies were designed. Rapids 1, and then it was followed by Rapids 2. 16 weeks randomized control trial of Bosentan versus placebo. 122 patients in 17 centers in the US and Europe. The primary outcome was the number of new digital ulcers developing during the 6-week study period. Next slide. Next slide. All right. So you'll notice that the red or orangey box, when there's less than 1, there's no change. When you get down to the point where you have 4 or more ulcers, you are likely to get some benefit from it by reducing the total number of new ulcers. Next slide. Rapids 2 was the same design, similar results. Thus, the group in which the greatest effect of Bosentan occurred was in the group who had or were at risk of developing 4 or more digital ulcers. Importantly, next slide. Bosentan does not promote healing of ulcers that are present. Next slide. Bosentan does not relieve the color changes and attendant symptoms of Raynauds, such as tingles or pain with Raynauds. An important subject was brought to light by Marco Matucci, who is an investigator in Florence, Italy. He has mobilized Europe to be a Scleroderma Consortium. He's trained a lot of docs in Europe how to manage scleroderma. And so one of the studies that came out is what I'm calling, what is the cost to the individual and to society of digital ulcers? Cost is not necessarily money here. This is quality of life, disability, and that kind of cost. Next slide. Okay, almost 1,500 patients with scleroderma-associated digital ulcers, or with a history of digital ulcer, or with a digital ulcer entry, were enrolled into this registry over a 5-year period. What they looked for and what they analyzed were people that kept coming for at least 2 years of observation, and that they had 3 follow-up visits during this 2-year observation period. Next slide. So, you don't necessarily have to come back to the doctor at 6 months. You're allowed a window from 3 to 9 months. Same for 12, 18, and 24. So there's a range where you could come back and be studied. Next slide. Now things are going to get a little complicated, and I'll try and simplify it when we get to a table. There were people that were characterized as no digital ulcers on follow-up. They may have had it before they got to the trial, but they didn't have anything during follow-up. So this is the mild form. Episodic, only 1 visit in that 2-year period with a digital ulcer. Recurrent was 2 or more visits with a digital ulcer and at least 1 visit where there wasn't one. Then there's the chronic that had 1 or more digital ulcers at every visit. So you see, as we go down the list, there are more frequent ulcers each time we change categories. Outcomes were analyzed at 2 years. The median number of follow-up visits was 4 to 5. Next slide. All right. So I'll try and simplify this slide. it's going to use the designation of no DU, episodic, recurrent, and chronic. And you see the blue here in no digital ulcer, there's no gangrene. As you start having more frequent and more of them, you get into the brown category where you have 22. The next is amputation, same phenomenon. If you're the no digital ulcer, you unlikely are going to have an amputation. But as you have more frequent and more of them, you are more than likely going to have some part of your fingers amputated. Infection was more common in people who had more ulcers more of the time. Hospitalizations were more as you got into more frequent ulcers. And finally, pain medicines. This is a big category because these hurt like hell, as everybody knows that ever gets a digital ulcer. They hurt like hell. So here, there was a lot of people who were on pain medicines, and some of these are probably even mild narcotics, the equivalent of Norco or Percodan. So all in all, what this shows is that the more ulcers you have all the time, the more likely you are to have some adverse outcome that is going to make you disabled or hard to have a good quality of life. Next slide. Okay, so same kind of headlines, no digital ulcer, episodic, recurrent, and chronic. So again, you start mild on the left-hand side and you start getting increasingly more ulcers more often, so you get to chronic. You'll notice that overall work impairment is only 10% if you don't have digital ulcers, but goes to 50% if you get chronic ulcers. Daily activity impairment goes from 10 with no digital ulcers to speak of to 60% with a lot of ulcers a lot of the time. Help needed, yes. Again, there's an increase. The more ulcers you get, the more troubles you're going to have. Hours of paid help, yes, that goes up. Hours of unpaid help, those are your friends, your relatives, anybody you know who can come help. Again, all of this shows that the more ulcers you have, more often and continuous, the more likely you are to become disabled. Next slide. So again, the more time that patients spend having digital ulcers in a 2-year period of time, the more likely they are to have more treatments, more morbidity, meaning other adverse health issues, and more disability. So our goal as doctors, and you got to help the doctors who are not up to speed, that our goal is to reduce the number and frequency of digital ulcers. That's what we want to do. Next slide. Here's Robert, 35-year-old disabled engineer with a 5-year history of limited scleroderma and Raynauds phenomenon. Over the years, he's had problems with recurrent digital ulcers, which have only partially responded to nifedipine at high doses in combination with sildenafil. Last winter, when he developed multiple digital ulcers, he was started on bosentan in an attempt to prevent more new ulcers. 6 weeks ago, he developed another crop of painful digital ulcers, and several had black necrotic tips. Next slide. So again, this is a slide from Neil Jones, 40 years old, but it still looks as awful as it did then. So this guy's in real trouble. Trying to go to work with a hand that looks like that, particularly if you're right-handed, is a real problem. Next slide. So again, we get the sildenafil, the tadalafil, and we may bring him into the hospital to give an infusion of epoprostenol. There are some sympathetic blocks, chemical, things induced into your neck, for example, or they may be done in your arm, near a nerve that supplies pain to try and knock out the pain. Botox is a current darling. Surgical and digital sympathectomy and regional block are other approaches. Next slide. Okay, Neumeister, there's not a lot of literature on Botox and Raynauds. Neumeister has published a couple of trials. This was the latest. He had a total of 33 men and women with Raynaud's phenomenon who were injected with botulinum toxin type A. Next slide. All but 5 patients experienced improved vascularity and relief of pain. Next slide. Laser Doppler scans illustrated notable improvement in perfusion. Next slide. 5 patients had repeat injections for recurrent pain. Next slide. Now, don't get me wrong, you're not going to the surgeon to have rectangular skin removed. That's just an artist's conception to show you where the injection's going. It's going where the palmar arch artery gives off digital arteries to the different fingers. So what you're trying to do is paralyze the muscle of the arteries that is constricted to get it to open up. Next slide. So axillary block is a something that is used from time to time. They would go into the armpit, look for the axillary artery and nerve, and inject something numbing, and you get improved perfusion. So the top right one shows very few little blips at the bottom of the graph. They then get the block, and suddenly there's more blood flowing through the fingers, and that's what you want. So a block is reasonable. They're only temporary, but in some people, they do a pretty good job for a while, and that can be done repeatedly if you need it. Next slide. Surgical intervention. Next slide. Ulnar obstruction. I showed you the angiogram from one patient that had an obstruction of the ulnar artery. There's a simple test called an Allen test. And the second the first black and white one there is my thumb pressing on the radial and ulnar artery. I then let go of one of the arteries and keep the other one obstructed, and I get a notion of how much blood actually gets back into the fingers. If it starts getting pink within 5 to 10 seconds, that usually means everything's okay. Then you press on the arteries again and have them squeeze to get the blood out, and then you have them release the other side, and you see whether the other side is obstructed. Now, ulnar is the most common. Radial I've seen, and I've seen, unfortunately, someone who has both arteries obstructing. The body will slowly make new circulations, but it takes time, and during that time, there may be a lot of ulcers and other nasty things. Next slide. You can then do an angiogram or an MRA, magnetic resonance arteriogram. Has a dye. Sometimes you can do a CT angiogram, which has a dye, and it will show you the radial artery is open. That's the bottom on the right. It goes to the thumb, and then there's an arch that goes at the base of the fingers. And there are little shoots coming out to the fingers. That's how the fingers get perfused. And there's ulnar artery absent. So some of the fingers on the ulnar side of the hand are going to suffer more. Next slide. I don't know whether Neil is doing many revascularizations. In other words, taking a vein out of your leg or using a fabric tube to kind of bypass the obstructions so that you can get a better circulation in the fingers. I don't know whether he's doing much anymore. Next slide. A digital sympathectomy. Again, this is from Neil, but Prosper Benheim at UCLA was trained under him and is a very good surgeon, nice man. And he has now taken on the task of trying to find out whether Botox works. So he often will try and get an approval for Botox and do the injections before he opens the hand. So what you see on the lower left is the palm opened up, and the surgeon will go in and clean out all the fibrous tissue that he can. And often the arteries that are in there are okay. They're just squished, so they can't get blood. Getting the fibrous tissue out, suddenly you'll notice that the right upper looks like there's no blood flow, and then in the lower right is blood flow. So he found that a lot of arteries were okay. You just had to get them out of the fibrous tissue. He then would sew up the hand, and most people had a good outcome. Every once in a while, infection would get in there and it'd be a little harder to get it to heal, but most everybody healed. Next slide. All right, so the summary here is calcium channel blockers reduce symptoms of Raynauds, but clearly not clearly shown to heal ulcers. I should really say dress warmly and dress in layers. September starts winter in California, and May is when it stops. And that has been reproducible most of the time. People start complaining in September and they quit complaining in May. Next slide. Prostacyclines work to heal. Unfortunately, Europe has iloprost, we do not, but we do have epoprostenol, but there's no randomized controlled trial with epoprostenol. We just use what we know about iloprost and hope that epoprostenol is doing the same thing. Next slide. Sildenafil and tadalafil orally work to heal and prevent. So if somebody comes to summertime and they don't think their Raynauds are very bad, they can come off their medicines. But in September, when things start chilling off, they probably ought to go back on them so they can get through the winter without as many ulcers. Next slide. Bosentan may prevent ulcers in patients who are at risk of greater than 4 ulcers, but it does not promote healing and is quite expensive, maybe $50,000, $70,000 a year. Next slide. Botox is promising, but there are no randomized controlled trials. Next slide. Surgical measures probably work to heal, but there are no randomized controlled trials. Next slide. My time has expired, and I guess we'll take questions, right?
Yes, thank you, Dr. Clements. Appreciate that very impressive talk.
Oh, okay. Well, everybody has access to it if they want to go back to it.
Yes, and that's what I always want to make sure everybody knows. I am recording this. I will make sure that everybody has a copy of this. I'll be sending it also to all of our leaders and sharing it on Facebook. So anybody that wasn't able to see it or just wants to watch it at their leisure, stop and start, take notes, because I think that's the best part, is being able to have it, click the link and be able to write your notes, especially when you go back to your doctor to talk about maybe some of these treatments or some of the things that you learned based off of Dr. Clements' presentation and the slides. So let me see, I got a couple things here. Let's see. Oh no, neither one of these are questions. I did have a few that were sent to me ahead of time. And one of them I thought was really cute that I just wanted to say. She put, I'm very interested in the information about digital ulcers. They are the bane of my existence, with exclamation points, which I thought probably many of you will probably nod in agreement of listening to this comment that was sent to me.
No, they are in agreement.
Yeah, absolutely.
And that study by Marco Matucci is showing that the more ulcers you have, the more troubles you're going to have. The quality of life goes down, the expenses go up, you're going to impose on your friends and relatives to help you. We just try very hard to get the ulcers to heal.
Agreed. I think that you basically have covered, you know, one person says, I'm going to start, I want to start working on healing my ulcers, but your whole presentation was based on what some of these treatments are. And to that question, now that you have this information, this would be something that you would go back to your local doctor and speak to them about the treatments that you've learned and see if there's something in some of the drugs that Dr. Clements mentioned that you can use. And
now, there are a couple of questions that have cycled through already. What was the first one I saw? Short memory.
I got it right here. Does any type of hand exercise improve circulation?
I don't think we know for sure. I think occupational therapy is a good thing. The occupational and physical therapists have not been very good about doing trials showing that their stuff works. So Medicare may limit how many visits you get because the proof that these things help is often absent. Now, if you have a personal experience with some of these techniques and you do get better on them, and then you kind of stop it and later you start having the same problem, you can ask for a refill or a revisit to an occupational therapist saying, the first time I did it, it helped a lot, but I've forgotten a lot. I want to go back and relearn it.
Good, thank you. Question, are these genetic? Maybe I think they're saying, is there a genetic
that was
component?
the first one. Every name I gave you is a generic name. I did not say one trade name.
It says genetic. I don't know if they're trying to say generic or if they're asking.
I think it's generic.
Okay.
The way it's phrased, I think it's generic.
Okay.
Now, is there a genetic basis for why some people respond to one drug and not another? This is an early field. And yes, there probably is some genetic basis to how people respond to drugs. So they may not respond to naproxen, but they may respond to ibuprofen or Celebrex. Some of this may be genetic response. Some people don't have a genetic receptor that allows them to get any effect out of a drug. And I don't know the topic well enough. Dan First might be able to help you with some of that.
Thank you. Is 20 milligrams sildenafil effective?
It's a starting dose. It's the one that is used for pulmonary artery hypertension. We will still get pushback from insurance companies to use it, even though that it is now generic. So then we have to do what they want us to do, which is to do a calcium channel blocker. Nifedipine, amlodipine are the ones that I usually use. But then I will do it for a month, and then I will reapply for sildenafil and say the calcium channel blocker didn't work, and I'm ready to move on. And then I get less pushback.
That's good information.
And sometimes I'll go to 40. Now, the original studies with pulmonary hypertension were done with 20, 40, and 80, 3 times a day. What they found was that the effect at 20 milligrams 3 times a day was about the same as the one at 80 milligrams. So they took the cheap route and made you pay more for the 4 milligram one. But most of the pulmonary hypertension experts will go from 20 to 40, 60, 80 sometimes, because there are a few hemodynamic changes in the heart, which they think are valuable. That's not going to cut any ice with the drug company that makes it. they're making too much money on having you take 4 20-milligram tablets instead of 1 100-milligram tablet.
Wow, thank you. I appreciate that you mentioned that you'll go back with some of these insurance companies and prove that something wasn't working. And now when you go back to them, they'll consider approving it. So I think everybody should take note of that with your own doctors. If this is something that's going on for you, you know that it can be fought for. So you might mention, well, Dr. Clements fights for his patients once they're not responding to a certain dose, and see if they would do the same for you. Thank you.
Is sildenafil safe for pregnancy? I think the answer is yes.
You got ahead of me.
There are people who have pulmonary hypertension during pregnancy. It's a bad combination. It's a real tricky management to get somebody with pulmonary hypertension through a complete pregnancy. The demands of pregnancy are that you increase your blood supply by 4 times. So the heart has to work 4 times as hard to get everything going. And if there's a plug in the system, like the pulmonary artery, it just makes it tougher. So we try and get people to avoid pregnancy when we can, and delay it when we can.
Thank you, Dr.
I realize sometimes there are breaks in birth control and they get pregnant anyway, but it just makes it harder.
Thank you. And thank you, Delia. Next question. Does the lack of blood flow also contribute to disformation of the hands?
Of the which formation?
Hands. Disforming of the hands.
Contractures?
I'm assuming the contractures, because it's asking if the lack of blood flow contributes to it.
As far as we can tell, it probably is a fibrosis process that gets into the ligaments and the tendons of the fingers that causes the contractures of the fingers, and not so much a blood supply issue.
Thank you.
Now, could it be? The answer is yes. The teaching in medicine is that it's primarily a fibrotic problem.
Thank you. Can doing angiograms cause problems like gangrene or damage to arteries?
All good questions can be answered yes. So I have to rephrase the questions to say, what is the likelihood? Angiograms used to be pretty standard stuff for Neil Jones. Then we started getting CT angios and MRA, magnetic resonance angiograms, and they're less likely to cause trouble. So in the hand, if you're looking to look at little tiny blood vessels, it may be difficult to make anything out of a CT angiogram. But my guess is the real angiogram where you put dye in the artery directly is pretty much a thing of the past.
Thank you. Next question.
And it's partly related to kidney function. These are excreted by the kidney, and if the kidney is not up to snuff, you have a creatinine of 1.5, then there may be some debate as to whether you should be subjected to that kind of risk.
Thank you, Dr. Clements. Is it common to have ulcers peel?
Yes.
Would that be if it was healing, or that's just part of it?
Inflammation sometimes leads to sloughing of the tissues overlying it. So I think it's just kind of a normal progression. Now, if the pain goes away and you start peeling, that's usually a good sign. Pain is a good indicator of how active an ulcer is. When the pain goes away, and I can I know from experience that I'll ask the patient, well, how's your ulcer? It's doing much better. When did it change? Well, I woke up on Tuesday and it felt a lot better. It can be overnight, where suddenly, as I see it, the body has made the decision of what's going to live and die. And the living part's going to get better, and the dead's just going to slough off or be removed. We try and reduce the amputations by surgery. If you have an infected bone, yes, you're going to lose it, because the circulation in the fingers is terrible to start with, and it really requires a good circulation and good antibiotics to get a bone to heal. So bone infections frequently wind up being amputated. The other is pain the patient can no longer stand.
Thank you, Dr. Clements. This isn't really Raynauds related, but I'll ask the question, and if you feel comfortable answering it. I've been experiencing thumb shrinkage, the nail bed shrinks, and I also can no longer close my hand around a cup. Can I do anything to stop the shrinkage?
Well, let's see. Is the length of the finger shrinking? Is the tissue at the end shrinking, and so the end of the finger isn't as long as it used to be? Is that what they're asking?
Angela, would you unmute for a moment to answer that?
No, the other fingers are not shrinking. It's just the thumbs. And I do have a couple of ulcers, not on the thumb, but on a couple of other fingers, but it's just the thumbs that are shrinking.
Okay, well, there's several ways that shrinkage can occur. One is the end of the finger, the bone at the end of the finger starts dissolving. It's being reabsorbed. So the calcium is disappearing, and the structure to hold the soft tissues up is gone. So the soft tissues will shrink down. I think that's what you're asking. Is that correct?
That's what it sounds like.
Yes. I mean, it's sore, it's painful. There's no actual ulcer, but it's definitely shrinking, because I can no longer hold the full cup in my hand, so I know it's shrinking.
Okay, well, if you haven't had a trip to the occupational therapist, they can help you teach you a few things about how to manage without the thumb being a primary part of the process.
Yeah.
Or you'll need the other hand to help you.
I do. I normally use both hands to pick it up. So yeah.
So you want to get a two-handled cup if you can find them.
Okay.
So that you got two hands holding the cup.
Right.
So if one doesn't work very well, the other one will hold it up for you.
Okay. Thank you.
And they make them that way. I don't know whether you can go online and look for two-handled cups. You probably can.
I'm sure you can. Thank you, doctor.
Mm-hmm.
Thank you, Angela. Thank you, Dr. Clements. Okay, next question. That was the one you answered or not? Is sildenafil safe for pregnancy?
I think it is. I probably would want to look it up first, but I think it is. You can probably go to Dr. Google and just put in the search term, is sildenafil safe in pregnancy? And you will get a list of different articles. Some will be worthwhile, some will be hype from drug companies, but you may eventually come to one that really answers the question.
Thank you. I have no digital ulcers, or CCB gave me horrible headaches, which we hear a lot. Are there any over-the-counter supplements that can prevent digital ulcers and or spasms?
I'm not really aware of anything that universally works. The problem often is that the studies that were done with sildenafil and tadalafil, for example, were not usually done by drug companies. They were done by individual investigators who had a burning question and wanted a burning answer. So they have devised and bought or cajoled the company to give them matching placebos and so on to ask the question. So my guess is Herrick's study did that. My guess the German study probably did that. There they have National Health Service kind of arrangements, so they can get drugs which don't require insurance. I mean, they can just get them, and they may be able to have their pharmacy make matching placebos. When we did the mycophenolate study against Cytoxan for lung, we had the Cytoxan pills were different than the mycophenolate pills. So we had to crush up and put them into matching capsules, which is a big deal. But it could be done probably in some of the European countries where things aren't as expensive for some of those. But often it's an individual investigator or group of investigators that wants to know the answer.
Thank you, Dr. Clements. What effect do beta blockers have on Raynauds?
Well, years ago, there were a few articles showing that in a couple of individuals, beta blockers led to worsening necrosis. Bad outcome. I don't use beta blockers very often in scleroderma, but I have used them from time to time, and I haven't had that kind of reaction. But people have to be aware that, yes, it can happen.
Thank you. How do calcinosis relate to or cause digital ulcers? My DUs have been in places where I have calcinosis.
Ask the question again.
How do calcinosis relate to / cause digital ulcers?
Okay, well, there is a different mechanism to the ulcer than the circulation, usually. Calcinosis is something that eventually will affect 50% of the people with scleroderma. It usually is found in the hand, but it can be found anywhere in the body. If you have an underlying ulcer, an underlying calcinosis over an ulcer, it's going to be very difficult to get that to heal. Depending on how big it is and how much trouble you're having, you can have a practiced hand surgeon remove the calcium deposit and sew it back up, and then it's more likely to heal. If that doesn't happen, then you might go to a wound care center where they can watch you very closely to see if they can get it to heal, even though there's an underlying calcinosis. They're difficult to manage.
Thank you, Dr. Clements. Jerry wanted to share with everybody, I have used Silver Sorb, and I think I'm saying this wrong, Puricol with AG. It works very well. I'm using it right now, and my DU is almost healed. What do you think of that kind of treatment?
So, trying to remember what the trade name is. Tell me what it is again.
It says Silver Sorb and Puricol, Puracol with AG. I don't even know what AG it means.
It's the chemical signature for silver.
Okay.
I think that's a reasonable thing to use, and I'm not sure what the mechanism would be other than reducing the likelihood of infection. I don't have a good answer for that.
Okay. But
If they're finding that it works, keep it up.
exactly, you took the words right out of my mouth. Thank you, Jerry. I've been experiencing ulcers and skin peeling repeated. I think it's supposed to be, well, he's saying repetitively, but I think it's maybe repeatedly for 2 years. It took 2 years for the doctors to figure it out until fingers turned blue and white. Do ulcers cause finger deformity? I think we already talked about this. My finger became crooked and deformed with the fingers to go to normal when Raynauds is controlled. Will it go to normal when Raynauds is controlled?
I don't think so.
Yeah, and you pretty much already said that you didn't think that there was a correlation with the changes of the fingers, sort of contractures and Raynauds, that it was a different reason for that. And so if I'm hearing you correctly, you're also saying even when the Raynauds is correct, under control, that's not going to change the bend in the fingers, right?
I think that's true.
Thank you. Okay.
Remember, I'm a practicing physician. My mother used to go to the doctor and say, she'd come home and say, I wish they'd damn quit practicing and get down to treating me. So anyway, we're practicing physicians, which means we're learning all the time.
Thank you, Dr. Clements. How do oral calcium channel blockers improve Raynauds?
Oh, that's a chemistry question, and that's far advanced from my level of chemistry anymore. There are calcium channels in cells, and I can't remember what the I forget what the chemical reactions are inside cells that make them effective. I don't know. I'd have to look it up.
Okay, but in the end, the reason that you're using these calcium channel blockers is to open up blood vessels and cause a dilation. Is that correct?
Yes, that is correct.
Okay.
But they have their biggest use in people that have only Raynauds phenomenon and don't have digital ulcers.
Oh, I'm glad you said that. So mostly just trying to get the Raynauds under control, but never really being used for actual ulcers, correct?
Yes, but insurance companies are going to make you use calcium channel blockers first. There is one exception. There was a Japanese trial of tadalafil. That was one of those that was included in the meta-analysis. Meta-analysis is a technique where you take small studies, pool all the information so you get a large number of people, and then you can often see that something really does work. Each study couldn't show it because it didn't have enough subjects, but if you get a bigger group of subjects, you can actually show that they work. Ask the question again.
Do oral calcium channel blockers improve Raynauds?
Or how do they?
Pardon? Yeah,
How do they do that?
Correct.
I still don't know. I can't. There's not enough room in my brain for trivia like that.
Thank you, Dr. Clements. Again, this one's a little, it's not specific to ulcers and Raynauds. Okay. Is bone resorption in the finger similar to bone resorption in roots of teeth? Do you know what causes the bone resorption?
I don't think we have good answers for why. It's usually the tips of the fingers that get reabsorbed. And the socket for teeth inserts into a socket, but has some fibrous tissue that actually hold the teeth in the socket. The socket gets reabsorbed and widens, but the fibrous tissue may not keep up with it, and the teeth may get wobbly. I don't have a firm answer to whether we can prevent that or stop it from happening.
Thank you. So I believe that as she's listening to this, she's saying calcinosis and ulcers are different. Are they both treated with amlodipine?
Well, if somebody has a calcinosis on the end of a thumb, for example, circulation issues tend to produce the ulcers on the fingertips and thumbs. Ulcers on the knuckles and the rest of the hand may not be vascular. They may be mechanical. You have tight, thick skin, and you bend the finger repeatedly, and it just pops open. So it's a mechanical issue. Some of these arguments are kind of moot because I will go ahead and treat with vasodilators for a lot of this stuff anyway, just to make sure that that end of things is being treated. Sometimes it works, sometimes it doesn't. With the ulcers on top of calcinosis, yes, I will still use sildenafil, tadalafil, realizing that this ulcer is going to be harder to take care of because of that underlying calcinosis. And then I will send them to wound care, where they will pay much more attention to the actual cleaning and making sure that they don't get infected.
Thank you. Some of these are just comments, and I want to go through them quickly because we have a lot of questions still. I have severe Raynauds and have numerous DO. I've had one Botox treatment, and that has significantly improved the healing. I'm a proponent of Botox. I wish insurance would pay for it. Oh, DU. I was wondering what DO was. Thank you, Anne.
Yes, that's a comment.
Yeah.
I can't help you there.
Let's see. I thought there were more questions. Let me see here. Somebody had sent me a message asking about any clinical trials that are going on for Raynauds. Are you aware of any right now that are going on? And I know that it's different for each state, by the way. Sometimes they'll be done in one place, but they won't be done in another.
Well, Suzanne Kafaja at UCLA is in charge of most of the clinical trials. I don't remember one specifically in Raynauds, but calling her office would be worthwhile.
Yeah,
and whoever picks up the phone can probably answer the questions about, are there any clinical trials?
okay. And also, you know, for many, going on the clinicaltrials.gov, and then what you do is you type in your area, and then you type in like the name of the disease, for instance, scleroderma, systemic sclerosis, and then you can start looking at the different trials that are being done, and you'll see that the ones that are being done in the different cities and states. And we try on our website, and most others do too, to keep an update going on our websites of the different clinical trials that are going on in scleroderma to help people learn. I personally look on clinicaltrials.gov. I call a lot of the scleroderma specialists and have them send in more personal information, like with eligibility criteria, and we'll put it on our website. So think about checking with your local doctors about any of the trials that are going on. They're not always on clinicaltrials.gov, but most likely, or most of the time they are. So I just wanted to add that. A couple other questions here. I've taken tadalafil for 3 years, which has helped reduce the severity of my DIs. Unfortunately, the side effects of tadalafil have caused me to have a partial hearing loss and blurry vision. Is the hearing loss and blurry vision permanent?
Good question, for which I don't have a good answer.
Have you heard of this before, Dr. Clements?
No, there was, when sildenafil came out first, there was a blue vision that would occur. What people saw had a blue texture to it, but I don't remember anything else. It could be, but I don't remember.
Thank you. Chris, I guess I have calcinosis and ulcers. Typically, I keep squeezing out some discharge. It then eventually heals once I get everything out. Painful process, but in time works. Is this unusual?
Trying to figure out whether this is one I have to take. Well, okay, ask me again.
I guess I have calcinosis and ulcers. Typically, I keep squeezing out the discharge and it eventually heals once I get it all out. It's painful, but it works. Is this unusual?
No. Calcinosis tends to be little tiny granules or a paste.
Okay.
So squeezing it out is a reasonable thing to do, because if it's gooey, you can get it out of there. If it's a lump of rock, then it's a little harder to do it at home. You know, surgeon take out the lump. But if it's paste and it comes out, that's good.
Thank you. You haven't mentioned digital ulcers in toes. Can that happen too?
Yes. It's harder to treat. Lower extremity ulcers is some place where I definitely have people go to wound care centers. I may go ahead and give calcium channel blockers and or sildenafil. Some people have low blood pressures, and when you give them amlodipine and sildenafil, the pressure drops too much. You can do without. Once we've got the approval for sildenafil, we can get rid of the calcium channel blocker if blood pressure management is too tough.
Thank you, Dr. Clements. And thank you for some of the comments that are coming in. Thanking you for your presentation. Thank you, Jeannie and Ilana. I appreciate it. And welcome to Jihan Abed, that's been visiting us from, he says that he's in Iraq and he's been living with scleroderma for 16 years. You know, you mentioned that you haven't been taking anything for the ulcers, but you're on rituximab. And I just want to say with this, presentation, you have information to bring back to your doctors to talk about what could be done to help you with some of these sores, whether they're old or not. It's just something that you might want to bring up to them. So welcome and thank you for your comment. Just more thank yous from everybody. We're pretty much out of time. We only really got about 10 minutes left. So I think that if there isn't any more questions, we'll probably just close shop. But I want to give everybody a moment just in case. Thank you, Ellen.
Yeah, thank you. Thank you for the thank you.
Dr. Clements, I have a parting question. If someone has has a history of severe ulcers and an amputation is potentially there, wouldn't it be harder? How does a patient with severe Raynauds heal an amputation if they already have trouble healing an ulcer?
Well, most stress is not good for anybody. I mean, there's some things that are good stress, weddings, that kind of stuff. A lot of it's just serous, hard stuff to deal with. If you can lower the amount of aggravation from things that are unpleasant, that would be a good idea. Now, that's easier said than done. So, yes, stress is definitely a factor in Raynauds.
Raynauds. But I'm talking about healing. The healing of an amputation, isn't that doubly difficult when you have severe Raynauds?
There are a couple of amputations we could talk about. There are people who wind up with necrotic fingers. The ends of the fingers are necrotic, and the soft tissues disappear, and you're left with a black stub. Those often are left alone and will fall off by themselves. The surgeons tend not to do much with them. unless you keep banging it and it opens up and gets to be, you know, an ongoing mess. But generally, they leave them alone and let nature do the healing.
Right.
Now, if you've got a good surgeon like Neil Jones and Prosper Benheim, they have been through this a lot, and they will try and work it so that there's loose tissue on the outside that they can close over the bone or the amputation. They don't want to stretch the skin, but they want it to be loose enough that it can easily close off the end and they can sew it up.
Mm-hmm.
That's the ideal.
Right. Right. Got it. Thank you. Thank you.
Dr. Clements,
Mm-hmm.
if I travel, I do travel to Europe off and on.
Mm-hmm.
Is it possible or am I easily able to get Ilipros over there?
To get which?
The Ilipros.
Ilipros?
Yes.
Um,
Is that recommended to do that?
well, if you've got bad ulcers that are not getting better with the simple stuff, they probably will do it. Now, I hear different stories from different people, and I never quite figured out exactly how much expense Americans are subjected to when they go to Europe. I've heard some people say that they had no charge for several days in the hospital, and then other people that say, no, it cost a fortune. So you probably have to figure out what the national health system will let you have for nothing or cheap.
Oh, so you have to go through hospitalization there first.
Well, you may be able, in our area, the nurses have fought to keep Ilipros and ipraprostanol administration in an intensive care unit.
Mm.
When we first did the trial 25 years ago, we were not forced to use the nursing staff to do the titration. We didn't have to put them in the ICU. Eventually, the nursing staff got nervous about having some of this done on the wards where there wasn't somebody closely watching them. And now it's, you have to go into an intensive care bed in order to get it.
Okay, thank you.
Now, in the National Health Service or some other country, it may not be. They may not have as rigid a plan of attack. They may be able to do it as an outpatient. You just have to find out from the system.
Okay, thank you.
Mm-hmm.
Thank you. You had a lot of thank yous from many people, and I just wanted to tell you all thank you, Chris, Claudia, Sandra, Mary, Daisy, and Jerry. Thank you all for your kind comments to both myself and Dr. Clements. And there is a couple questions from, can Raynauds be reversed, and can Raynauds be managed without medication?
Well, if you have primary Raynauds, meaning you don't have a connective tissue, including scleroderma, yes, you don't need medicines. If you start getting digital ulcers, it gets very difficult to heal them without some medicines. Can you do it? You probably could. You could probably leave your house at 80 degrees and stay in, you know, jackets and layers and stuff. It might be enough to get it to heal. Most people that I've seen with these things are not willing to go to 85 degrees in their house. Their husband hates it. Their kids hate it. Sometimes they'll go off in a separate room and have a space heater, which is not a bad idea, but you still have to come out and have dinner.
And you got a couple more thank yous, Kelly and Faye. Thank you for your medical knowledge. I appreciate all of your support, love, and care. I greatly appreciate everything you do. And thank you,
Thank
Dr.
you.
Clements and Tina, valuable information. Thank you both, Kelly and